So we will continue here. I'm chairing the session with Tara Kent. As you know, this is one of the most important sessions of the meeting. So there will be discussions for each paper. We will appreciate that the discussant speaks in the microphone, and then the speaker can stay here and answer the questions. So the first paper is neoadjuvant chemotherapy resulting in suboptimal CA19-9 response associated with no survival benefit compared to surgery, first approach in resectable or borderline resectable pancreatic cancer. And this is going to be presented by Howard Yu from the United States.
All right, good morning. I'm Hao Liu. I'm a general surgery resident at University of Pittsburgh Medical Center. Today I will be presenting our work highlighting CA19-9 response to neoadjuvant chemotherapy associated with postoperative survival and treatment failure pattern in early pancreatic cancer. I have nothing to disclose. Neoadjuvant chemotherapy is gaining popularity over the surgery-first approach in treating resectable and borderline resectable PDAC. Advocates for neoadjuvant chemotherapy expected theoretical benefits of treating micrometastases early and allowing more patients to complete multimodality therapies. All these benefits of NAC were expected to prolong survival. However, there is significant heterogeneity in NAC delivery and response, and above all, there is no definition of effective neoadjuvant chemotherapy in this clinical scenario. There are a few outstanding questions in the challenges that I just described earlier. First, what are the postoperative survival and patterns of failure in resectable or borderline resectable PDAC patients who received NAC, and how does that compare to patients treated with surgery-first approach? And second, is there a biomarker that measures the response other than the delivery of NAC that can dichotomize the NAC patients undergoing resection into groups of distinct survivals and recurrence patterns? So previously, we published a retrospective study showing that CA19-9 change of normalization and greater than 50% decrease may have particular clinical significance. Here, the two graphs were showing that patients whose CA19-9 did not normalize or failed to drop greater than 50%, in these patients, adjuvant chemotherapy was associated with no longer survival. On the contrary, patients whose CA19-9 normalized and had greater than 50% decrease have to fulfill these two criteria. Their survival seems to be not benefiting more from additional adjuvant therapy. This study was limited by retrospective selection bias of our institution with some short course neoadjuvant trials when adjuvant regimens were mostly gemcitabine monotherapies. Regardless, it demonstrated the value of CA19-9 as a biomarker to measure NAC response at the time. Therefore, we hypothesized that in resected early PDAC patients, CA19-9 optimal response of normalization and greater than 50% drop may be an indicator for effective neoadjuvant chemotherapy, which is associated with longer postoperative survival and a different recurrence pattern, while patients who did not achieve this threshold would have similar postoperative outcomes to surgery-first cohort. So this is the patient flow diagram. Of 631 patients we screened, 586 patients were included in the analysis. We had 219 patients who went surgery first, in which 117 patients had elevated CA19-9. We also had 367 patients who had neoadjuvant chemotherapy, in which 59 patients had presented with elevated CA19-9, which normalized with a greater than 50% drop after neoadjuvant chemotherapy, therefore categorized as the optimal responders, and 134 patients who either did not normalize their CA19-9 or if they normalized, had a very minor drop, for example, 41 to 36, that kind of drop, therefore categorized as suboptimal responders. Of particular interest, I would like to highlight the proportion of adjuvant chemotherapy. Roughly about 70% or more patients received part or all intended adjuvant chemotherapy after resection in all groups. I would like to clarify the chemotherapy parameters for you to better understand the limitations of this study. We only characterized as receiving or not receiving, so basically yes or no. And we also did consider treatment regimen. We could not consider cycle numbers because different regimens have a different days for each cycle, or we did not accommodate all changes in dose reduction or treatment holidays or so on. Instead of measuring for delivery, we focused on response and abstract CA19-9 before and after neoadjuvant chemotherapy. Here are the baseline characteristics of the entire cohort. We can notice that patients who had NAC have slightly larger tumor on EUS and eventually higher vascular resection rates. On pathology, they tend to have smaller tumors with less lymph node involvement at less invasions without any difference in positive margin rates. Patients had comparable rates of receiving adjuvant chemotherapy as I showed before, and although neoadjuvant chemotherapy group received slightly more adjuvant radiotherapy and salvage therapy, I would like to say that none of these two were associated with longer survival. In the subgroup analysis, where we consider CA19-9 response, although the differences between the surgery first group and NAC group still existed, the optimal and suboptimal responders had similar baseline characteristics, including EUS size and presentations, although the baseline CA19-9 was much higher in the suboptimal responder group. Also, the NAC regimens were similar. Again, the baseline between the optimal and suboptimal responders was similar, including lymph node ratio at the final pathology, and also postoperative treatment, besides slightly lower PNI rate and smaller tumors. We focused on the postoperative survival since we did not include patients who we started with neoadjuvant chemotherapy but could not proceed to surgery. We did not perform an intention to treat analysis. Therefore, we chose the start of our follow-up at the time of surgery other than the time of diagnosis to avoid the immortal time bias. To examine patterns of treatment failure, we recorded all first and subsequent radiological progression by CT scans. The statistical models used will be mentioned when we present specific results. When available, multivariable adjustments were made using all the parameters shown in the last slides. For clear presentation, only parts of the forest plots were shown in subsequent slides, even if adjustments were made for more covariables. So unadjusted analysis of the entire cohort showed that NAC was associated with longer survival. However, when we adjusted for baseline, pathological, and treatment parameters, the hazard ratio for receiving NAC lost its significance. Therefore, NAC is not associated with longer postoperative survival than the surgery first group if we do not consider treatment response. Now, if we divide the NAC group into optimal and suboptimal responders, optimal CA19-9 responders had significantly longer postoperative survival, represented by the difference in the two lines. I wasn't able to go back. Let's see. Yeah. So the optimal CA19-9 response had significantly longer postoperative survival, represented by the difference between the red and blue line. We found similar results in multivariable adjustment analysis, where again, CA19-9 optimal responders is associated with longer postoperative survival. However, of particular interest, we found that patients with suboptimal CA19-9 response had post-resection survival that is inseparable from the surgery first group. This is represented by the largely overlapping blue and green lines. Suboptimal CA19-9 response also had a hazard ratio of 0.99 in the multivariable adjusted Cox regression. Even when we count survival from the time of diagnosis, which attributes the entirety of immortal time bias to the efficacy of neoadjuvant chemotherapy, we don't observe any benefits other than just the immortal time bias, demonstrated as the parallel relationship between the blue and green line, as well as the hazard ratio of 0.86 with non-significant p-values. Therefore, suboptimal CA19-9 response had similar survival to the surgery first group. We then proceed to analyze the patterns of treatment failure as metastatic progression or local recurrence, first appearing in different organs or sites as competing events. So this figure shows the cumulative incidence. This figure shows the cumulative incidence functions stacked together with different colors representing different sites of first progression. Visually and statistically, there is no difference in the recurrence pattern between surgery first and NAC group, when treatment response was not considered. However, when we divide the NAC into optimal and suboptimal responders, which are shown in the middle and on the right, we can see that a significant reduction in the cumulative incidence of liver first metastases only in optimal responders. This is represented by the red stripe in the stacked cumulative incidence figure, where the width of the red stripe representing liver-only metastases as the first site of progression. Not only that, we also see that when CA19-9 response was suboptimal, there seems to have no difference in recurrence pattern than surgery first cohort. When we consider both competing risk of the first progression site and neoadjuvant chemotherapy response, the time and cumulative incidence of first progression in the lung, peritoneum, local recurrence, or multiple sites were not different, even in the optimal responder group compared to the surgery first group. However, when focusing on the radiological first progression in the liver, the significantly longer time and lower incidence of liver metastases are occurring only in the optimal CA19-9 response group. And let's focus on the panel in the left lower corner. We performed multivariable adjusted regression considering competing risks, correcting for all the clinical pathological covariables shown before. This lower incidence of liver metastatic progression in optimal CA19-9 responders was still statistically significant. So we're going, because of the time,
We are short of time. Thank you.
Going to the conclusion. Therefore, summarizing our results, we showed that suboptimal CA19-9 response to NAC correlated with no survival benefit compared to the surgery first approach, and optimal CA19-9 response to NAC is associated with longer survival and a different recurrence pattern. Thank you very much.
Thank you. Isabella Frigerio from Italy will be discussing this paper. Isabella.
Okay, thank you, Dr. Liu, for your talk and for your interesting results. I think that putting all the efforts try to identify what we call responders among patients with pancreatic cancer, the ones who might benefit from a surgical resection, is a sort of philosophical stone for all pancreatic cancer researchers. We know that pancreatic resection still sits in the top level for postoperative morbidity and mortality rate. But at the same time, we know that surgical resection may represent the only chance for these patients to be cured. You clearly demonstrated that CA19-9 is, when expressed, because not all the population has this antigen, 10 to 20% of people are US negative, so we cannot help them in this way. But you clearly demonstrated with your results that when expressed, CA19-9 correlates to survival. And I'm not really surprised by this result because it's a confirmation of its predictive role. What surprises me is its correlation and the correlation of its delta with a different pattern of recurrence. I mean, optimal responders, you showed that they are less likely to develop liver metastases in their follow-up. And I wonder if you made any hypothesis for this, because if I have to do one, probably I would think that these patients, the suboptimal responders, the ones who developed liver metastases, probably they already had a micrometastatic disease to the liver at the time of diagnosis. And they simply recurred where they already had the disease. The relevance of having these prognostic factors, and CA19-9 is one of the factors that we already know. I think they all are separate elements and independent elements that are part of a more complex multifactorial predictive system that can increase the power of its prediction if used all together. And we already have study that does this. We already have study that puts CA19-9 with other known independent factors like tumor size or local staging. And at the same time, we know the limits of radiology to define the local staging after chemotherapy. But here new tools are coming to help us, and I think that artificial intelligence would play an essential role in this area of research. We already have studies that tell us that texture analysis of pancreatic cancer after chemotherapy, even without a decrease in size, would help us to predict good or poor histological prognosis. And if this is connected with the delta of CA 19.9, it can predict overall survival as well. So I think that one way to use this predictive value is to correlate with others. Another thing, and I will live with that, and I want it to be a little provocative, is after we have done all this work trying to identify predictors, how do we use them? The meaning of a predictive system, I think that it sits in the way that it can modify my clinical decision and the way that I manage my patients. Otherwise, it might sound like only to be speculative. So how would you use these results that you had? How many of the surgeons in this room would not operate on a patient who had a reduction of the tumor after chemotherapy, maybe started from locally advanced, and a reduction of CA 19.9, but where our predictive system tells us that it's not going to survive more than 10 months after surgery? I think very few of us, maybe no one. Thank you.
Thank you so much for your questions. To answer your first one about the differential response of the metastases at different sites, different hypotheses, I think it's the tumor microenvironment at different organ that actually made a different response. So for FOLFIRINOX and Gemabraxane, I think they were originally developed by treating metastatic disease, and we are borrowing them from treating it in a neoadjuvant and adjuvant setting. None of those studies were actually differentiating what kind of metastases that are responding at all. So liver metastasis being one of the most prominent sites for metastases, they are responding to those treatments, and those treatments are probably being selected because they actually can treat liver metastases. However, the lung metastases, even if they don't respond, probably was not really having a big impact in the original trials that established FOLFIRINOX and Gemabraxane. So I think in terms of the differential response, we probably should also look into other regimens that can actually affect like lung metastases or local recurrence. Some people will argue that lung metastases does not kill patients, but I would say it still affects clinical practice because when you have a patient who developed lung metastases while on neoadjuvant chemotherapy, you would not offer them surgery.
Thank you. Thank you very much.
Yeah, we can have the discussion afterwards, I think, for the sake of time. Thank you very much.
We need to proceed with the next paper. Thanks.
Thank you.
So we'll move on to our next paper now, which is a multi-center randomized phase 2 trial of prophylactic right half dissection of superior mesenteric artery nerve plexus and pancreatoduodenectomy for pancreas cancer by Suguru Yamada from Japan.
It is my great pleasure to be able to present our study here. We appreciate it profoundly, Congress Chairman, Professor Chapman, and Drs. Kent and Lindrow. Today, I will talk about multi-center randomized phase 2 trial of prophylactic right half dissection of superior mesenteric artery nerve plexus in pancreatoduodenectomy for pancreatic head cancer. I do not have a financial interest, arrangement, or affiliation with one or more organizations which could be perceived as real or apparent conflict of interest in the context of the subject of this presentation. As a study backgrounds, historically, right half dissection of the SMA nerve plexus in pancreatoduodenectomy for pancreatic head cancer was initiated to accomplish outer dissection. However, subsequently refractory diarrhea were thought to be a major concern. Therefore, this study aimed to evaluate the necessity of this technique. Eligibility criteria of this study is shown here. First of all, planned pancreatoduodenectomy for pancreatic head cancer. Second, no invasion of the SMA nerve plexus on preoperative imaging studies, and estimated outer dissection by preservation of the nerve plexus. Finally, age between 20 and 75 years old. Primary endpoints were set as local recurrence rate at 2 years. Second endpoints were frequency of the area, accumulation of sites, peritoneal recurrence rate, initiation of adjuvant chemotherapy, recurrence-free survival, and overall survival. This is a study schema. We divided the enrolled patients into Group A and B. The right half of the SMA nerve plexus between middle caudate artery and SMA root was dissected in Group A. On the other hand, SMA nerve plexus was totally preserved in Group B. These are typical intraoperative photos. As you can see, right half dissection of SMA nerve plexus was performed in Group A, whereas the SMA nerve plexus was totally preserved in Group B. I show the control diagram here. A total of 80 pancreatic head cancer patients for whom pancreatoduodenectomy was planned were enrolled. They had no invasion of SMA nerve plexus on preoperative image finding. The patients were randomized based on institution, portal system invasion, and preoperative radiation therapy. 3 patients showed the pathology other than pancreatic cancer postoperatively, and 3 patients deemed to be unresectable. Therefore, 37 patients in each group were analyzed. This is a comparison on preoperative clinical variable between the groups. There was no difference regarding age, sex, performance status, body mass index, NCCN resectability status, tumor size, preoperative biliary drainage, neoadjuvant therapy, including radiation therapy, and various tumor markers. As for intraoperative clinical variables, there was no difference regarding operative time, blood loss, portal vein dissection rate, blood transfusion rate. Concerning the postoperative variables, there was no difference of pathological invasion of SMA nerve plexus, residual tumor including SMA margin and dissected pancreatic margin, and USCC stage. This is a comparison of short-term outcomes, especially postoperative complications. As for a frequency of the area evaluated by CTCAE version 4, the dissection group showed postoperative area of 70.3%, which was higher than that of preservation group. However, there was no statistical difference between the groups, including the grade. Also, there was no difference of opioid use. As for other complications, we could not find a difference of pancreatic fistula, postoperative sites, intraoperative abdominal infection, delayed gastric emptying, and intraabdominal bleeding. When we compared the other short-term outcomes, there was no difference regarding reoperation rate, hospital stay, 30-day mortality, 30-day readmission. As for adjuvant chemotherapy, there was no difference of initiation rate, start of treatment, completion rate, and performance status. We examined a time-course postoperative diarrhea evaluated by CTCAE grade. Group A dissection group with a higher grade than that of grade B, preservation group during 6 months after surgery. However, there was no difference between the groups 1 year after surgery. Also, the postoperative diarrhea was gradually controlled over time. When we focused on the CTCAE grade 2 or 3 postoperative diarrhea, Group A showed a higher ratio than that of Group B. However, such a severe diarrhea was gradually controlled over time, and we could not observe a difference between the groups. Finally, it shows the survival outcome between the groups. This is the recurrence-free survival curves in which Group A, the section group, revealed a tendency of better survival than that of Group B, preservation group. However, there was no statistical difference between the groups. This is an overall survival curve between the groups. Similarly, in recurrence-free survival curves, Group A showed a better survival till 36 months after surgery. However, no statistical difference was observed. Initial recurrence patterns were examined between the groups. There was no difference regarding all recurrence rate, local, regional, and systemic, including peritoneum, liver, lymph nodes, and lung between the groups. This slide shows a local recurrence rate due to the extent of SMA nerve plexus dissection. Gen and Innovative studies could not demonstrate a clinical benefit of the SMA nerve plexus dissection, but Nakagawa's studies showed a statistical difference. In conclusions, could not demonstrate the clinical impact right of dissection of the SMA nerve plexus on local regional recurrence or survival. Therefore, the prophylactic dissection of the SMA nerve plexus is unnecessary, given that refractory diarrhea could be included by this technique. Thank you for your kind attention.
This paper will be discussed by Chuck Vollmer from Philadelphia.
I wonder, they're being beamed in, I guess. He's going to be live here.
I think so.
I'll start off until that goes on. I thank the moderators for the opportunity to comment on this best of the best paper.
So, Chuck, yeah, he's coming.
Yeah.
Okay.
Hello.
Hey,
Hi, Dr. Yamada.
How are you?
good.
Congratulations, Dr. Yamada, for embarking upon a phase 2 randomized controlled trial. You describe an extended dissection technique whereby the nerve plexus along the SMA is half dissected. Interestingly, this added maneuver did not seem to actually clear more disease, appreciably influence the margin positivity rates, or decrease local recurrence. Although not statistically significant, diarrhea occurred considerably more often, 70 versus 50%. Frankly, it's hard to know how you can tease out the driver of the diarrhea seen, whether it be from exocrine insufficiency from the operation or the effects of the nervous sympathectomy. I have a few questions to ask you. It's hard to conceive for many just what this looks like. I personally have never felt that I have ever identified a nerve plexus, particularly in our often obese patients. Your BMI is a mere 21. The depiction of your study schema slide is not what I see, nor what many of my peers here in the Americas regularly see. In particular, how does one know by the preoperative axial imaging whether this radiographically indistinct plexus is invaded, since it is apparently a breakpoint in determining eligibility for your study? My second question is, it's hard to know what the study is powered for: diarrhea presentation or recurrence rate, or whether either is properly calculated for. For both outcomes, what are your parameters for determining a clinically significant difference? For instance, since this plexus is actually involved with tumor only 6% of the time, such a low frequency scenario, how can this study be adequately powered at 37 patients per arm to show a difference in the outcome of recurrence? Overall, I would agree with the ultimate conclusion that you have made and congratulate you for actually making it, instead of forcing what we all would hope to be the case. This technique appears to provide no overt value and may be detrimental to patients. However, I doubt that this study lasted long enough to definitively declare that. Thank you very much.
Thank you so much. First of all, as for imaging studies, we check the patient, and we check their CT image and enroll the patient to this study. So we use their dynamic CT image to see their SMA invasion. Second, the local recurrence rate at 2 years after surgery in right half dissection group, that is group A, but we estimate it to be between 15 and 20%. So I assuming null hypothesis of 30% and an alternative hypothesis of 10% is a one-sided type 1 error of 0.05 and power of 0.9. So enrollment of 37 per patient per arm was required. That is answer. Thank you so much.
Thank you. If there's any other question, we have time for one, probably one more. I'll ask a brief question just to further emphasize about technically how one identifies this plexus in a patient. What has been your experience in patients who may be on the higher end BMI spectrum in your patient population? As Dr. Vollmer said, many of our patients here in the U.S. have much higher BMI. How would you identify this nerve plexus, either preoperatively or intraoperatively adjust for the more obese patients?
So we basically check their preoperatively SM invasion for the patient. So yes, we use their dynamic CT imaging to check their SMA invasion.
Okay, thank you very much.
Thank you, Dr. Yamada, for connecting.
Thank you so
Dr.
much.
Vollmer, for your comments. So our next paper is failure to potential cure high-quality surgery for gallbladder carcinoma is infrequent, associated with disparity, and not substitutable by chemotherapy. This is going to present by Eduardo Vega, and this is from USA, multi-center study. Eduardo?
Yeah, good morning, everyone. I want to thank the society and Dr. Lindoa and Dr. Ken for the kind invitation of presenting our work in this session. So my presentation will be the buy-in background, objective, patient method, results, and summary. Let's talk about some background. Oncologic surgery for gallbladder cancer, certainly for T1B to T3 gallbladder cancer, require at least a gallbladder fossa resection or a bisegmenectomy with portal and retropancreatic lymphadenectomy. However, we wanted to see how frequent is this done in a national context and which factor could be associated with a low-quality surgery. So we used for that the National Cancer Database from 2004 to 2016. We decided to only include patients with stage 1, stage 3, specifically T1B and T3. And then we divided those in surgical quality. We define high-quality surgery as an oncologic extend resection, meaning the gallbladder fossa I already mentioned, plus the lymphadenectomy. However, that lymphadenectomy have to have at least 6 lymph nodes, and those patients have to have R0 margin. Fail to do so is defined in our study a low-quality surgery. So this is a consort diagram that shows you that we found in the NCDV at least of 25,000 patients. However, after a strict exclusion criteria, and this is something also that we were amazed, we only found almost 4,000 patients, divided in high-quality surgery, 368, and low-quality surgery, 3,500 patients. Let's talk about result. It's a table that show comparison outcome from high quality surgery to low quality surgery. Obviously, you can see that low quality surgery has patients with positive margin. However, it's a 26% of positive margin patient. We understand also that lymphadenectomy was done only in about 55% of the patient, and hepatectomy even lower, 35% of the patient. This can be all summarized in this brief slide of, we found in low quality surgery patient 26% of R1 margin, only 55% of lymphadenectomy, 34% of hepatectomy. We have a higher mortality and a lower rate of adjuvant chemotherapy. This is a Kaplan-Meier curve that is stratified by quality of surgery. You see, as a high quality surgery, the solid red line. And it's clear for us that in this graphic, high quality surgery is also pertain better survival. And this is even in patients with adjusted, and even in this subgroup of patients are stereo resection, obviously. But we went a little bit further. We wanted to study and understand those low quality patients and how can we improve those low quality patients. And this is a Kaplan-Meier of adjuvant chemotherapy use in those quality and low quality patients. You see here, again, in this case, in a green solid line, the high quality patient without chemotherapy. It's still significant different from low quality surgery without chemotherapy. And even though low quality surgery with adjuvant chemotherapy is significantly better than low quality surgery alone, that's not actually able to achieve the survival we had with high quality surgery. So we went to understand which are those factors we can modify and what is the predictive factor that will delineate which patient will get high quality surgery and which patient will get low quality surgery. We finally, in the multivariate analysis of this logistic regression, found that private insurance, yes, has better chance to have high quality surgery. Higher income has also better chance to have high quality surgery, just like higher education. However, when patients are diagnosed in urban and rural and not in metropolitan, they have more chance to have high quality surgery. And obviously, stage 3 patients have more chance to have high quality surgery. On the contrary, low quality surgery are older patients, high comorbidities, and in this case, laparoscopic approach was related to achieving low quality surgery. Again, no surprisingly, facility type can incrementally improve the high quality surgery rate. However, academic research center, at least in the National Cancer Database, is only for 14.9% of the patient. In summary, high quality surgery in a National Cancer Database is infrequent. We do have multiple factors that we can intervene. Adjuvant chemotherapy does not replace high quality surgery, even so in gallbladder cancer. And centralization, open approach, private insurance status may improve the high quality rate and survival of those gallbladder cancer patients. Thanks.
Thank you, Eduardo. The paper is going to be discussed by Javier Zavala from Clínica Alemana, Chile. Javier?
Well, first I want to thank for this opportunity. For me, it's an honor to be here and to comment a paper from Eduardo. Well, this is a very, very interesting paper because we are all time we comment papers focusing about surgical techniques, but not from this global vision of the management of gallbladder cancer. The authors define very well the title of high quality surgery. So they define patients who underwent a lymph node dissection of at least 6 lymph nodes, an R0 resection, and also patients who underwent a liver resection. And the primary outcomes of this paper was the evaluation of the factor associated with the high-quality surgery, and also the role of the adjuvant chemotherapy in these patients, in both patients who had a high-quality surgery and patients who had a low-quality surgery. The paper was based from data from the National Cancer Database that it represents the 70% of newly cancer detected or diagnosis in the US. So it's a very large population of patients. Patients were collected from 2004 to 2016, and it included patients with T1B, T2, and T3. And the patients were selected according if they had an intent of cure surgery. So the objective and the material is very clear of the patients who were studied. They collected more than 20,000 patients, but for this paper, the patients that meet the inclusions were only 3,700. And for me, it's interesting and a little worry that only 9.6 patients had a high curative surgery. So only 640 patients had a quality surgery. So have a surgery who has the potential to cure the disease. Less than 10% of all patients who were in this National Cancer Database. The mean age of the patients was higher than the mean age that we read from different papers. It was in these papers 70 years old. And when we analyze the results, it's surprising that high-quality surgery was more associated to private insurance, was associated to people who live in urban areas versus metropolitan areas. And for me, and I would like then to ask to the authors, these patients with high-quality surgery had more stage 3 patients. It's surprising because everybody think that patients with T1 or T2 patients were more favored to have undergone a high-quality surgery. Further, patients with high-quality surgery had more chemotherapy, and probably this because patients who had more high-quality surgery were treated in academic institutions, and then they had the chance of getting chemotherapy also. According to survival, the author chose a clear difference between high-quality surgery and low-quality surgery. Median survivals for high-quality surgeries was 55 months, instead 22 for patients who had a low-quality surgery. In order to the study about chemo, unfortunately, we don't know the type of chemo that was employed, but chemo improved the survival in both, in high-quality surgery and in low-quality surgery. But it was not possible for the low-quality surgery with chemo to get the results of the high-quality surgery. So surgery is and we all know that surgery in gallbladder cancer is the crucial treatment to get survival. When they did the logistic regression, their results were almost similar. So was associated the high-quality surgery to private insurance, higher income, patients who live in urban and rural areas. Again, stage 3 appear as more associated with a high-quality surgery. And also, a longer time between diagnosis and treatment was associated with high-quality surgery. And I understand it's probably because the presence of incidental tumors in patients who underwent a high-quality surgery.
We are running out of time, Javier.
Okay.
Okay.
So finally, I want to congratulate the authors. It's a very interesting paper because they focus the management of the gallbladder cancer from a different point of view that we all the time we do. Thank you very much.
Thank you, Javier. Eduardo, short
Yeah.
answer, please, because you have to.
Yeah, very brief. I think the stage 3 prevalence of high quality surgery is just upstage from the lymphadenectomy. So they were able to find lymph node positive, and that's the reason why they were able to classify those patients as stage 3. So there is an upgrade of the lymphadenectomy in those patients. That's the reason why it's more prevalent. Type of chemo, as we may know, National Cancer Database is not that granular that give you a type of chemotherapy, but we were able to actually analyze single and multi-agent, and even in both of those cases, center who had higher rate of high quality surgery give either single or multi-agent. And yeah, did we mention anything about laparoscopic? No. Yeah, I think laparoscopic approach is, although we have published about that, and we think, and our group think that in a specific center of expertise of liver, minimally invasive liver surgery, it can be done safely. What reflect in this study that those patients need to be referred to those centers. Thanks so much.
Thank you, Eduardo. Thank you very much.
We'll move on now to our final paper of the session, which is domino liver transplants. After a quarter of a century, are we still wasting too many usable grafts? To be presented by Ola Ahmed.
Good morning, everyone. My name is Ola Ahmed, and thank you to the IHBBA for the opportunity to present this study on behalf of Washington University in St. Louis, titled Domino Liver Transplants After a Quarter of a Century, Are We Still Wasting Too Many Usable Grafts? So I have no relevant disclosures for this study. So as a brief background, it's been widely reported that organ shortages have really plagued all forms of solid organ transplantation. And a recent study has indicated that only, less than 10% of organ transplantation needs are met globally. And liver transplantation is certainly no exception to this. And by the end of 2019, there were still over 12,000 candidates waiting for a transplant here in the US. So to address this, there have certainly been many strategies to try and expand the donor pool. And many of these outcomes have been presented at this very meeting. So many centers are becoming much more aggressive with their use of marginal allografts and DCDs, which are becoming much more common practice. Several high-volume specialist centers are really continuing to explore the full spectrum of liver transplantation techniques, using more living donors and split liver allografts. National policies have also been implemented to try and promote greater and broader organ sharing. And most recently, novel machine preservation technology has really helped to optimize the use of marginal allografts, again, in an effort to increase the donor pool. Another less popular strategy, however, is domino liver transplantation. And the basic principle here is that some inherited disorders or metabolic conditions can be corrected with liver transplantation. However, they still result in a structurally sound explanted liver that can then be implanted into a carefully selected recipient. So to capture global data, the Domino Liver Transplant Registry was set up in 1999. And by December 2019, over 1,200 domino liver transplants from 67 different hospitals in 21 countries were recorded. And most of the volume seems to come from Europe, while the US has really only contributed to 10% of the global registry's volume. However, despite the national volume remaining low, a very encouraging article from Ohio, a propensity-matched analysis, sought to compare domino liver transplantation with deceased donor liver transplants. And they found that there was no statistically significant difference when both groups were compared when it comes to mortality and graft survival. However, long-term survival has remained objectively unreported in US populations, and how these donors contribute to the overall donor pool is certainly worth considering. So, to address this knowledge gap, the aim of this study was to assess the national utility, the uptake, and the survival of domino liver transplantation here in the US. So we queried the UNOS database from 1987 to 2020, looking for all domino liver transplant procedures, and we looked at both adult and pediatric donors and recipients. We also looked to non-domino liver transplant indications for surgery, And we looked at graft and patient survival, looking at short and long-term outcomes. So in total, over 180,000 liver transplants were performed in the US during the study period. And the first domino liver transplant occurred here in 1996. Since then, there's only been 185 domino liver transplants recorded here in the US based on UNOS, and this accounted for 0.1% of all domino liver transplants performed. So out of 146 US liver transplant programs, only 29% have ever performed a domino procedure, and more than half of these have performed less than 2 cases during the 25-year period. So this is a graph that illustrates the annual frequency of domino liver procedures occurring in the US since 1996. And while there was an initial encouraging increase in volume, this has remained largely static over the past decade. When we looked at patient demographics, there was a male preponderance when it came to both domino donors and domino recipients, and the median recipient age was 60 years. So to look at severity, disease severity, because we included cases dating back to 1996, we had to categorize liver severity based on the pre-MELD era and, of course, the modern MELD score. So when we looked at the domino donors, just under 50% would have been considered as having severe liver disease, falling into either a status 1 or with MELD scores greater than 30. When we looked at the domino recipient end of things, interestingly, less than 10%, or just about 10%, would have been considered as having imminent liver disease with high MELD scores, and the vast majority of the domino recipients would have had mild to moderate disease. We then again looked at domino donors, so over 80% of donors were adults, and the underlying diagnosis or the underlying indication for transplant in domino donors was amyloidosis in 56% and maple syrup urine disease in 27%. So then when we looked at the domino recipient end, 88% of domino recipients were again adults, and the main indication for transplant was malignancy in 24% of cases and viral hepatitis in 20%. So adult to adult domino donations were the most common, accounting for 76% of cases. Pediatric to adult was 11%. This was followed by pediatric to pediatric domino cases, which were 8%. And adult to pediatric domino procedures accounted for 5% of the total volume in 25 years. We looked at waiting time, and for both adult and pediatric recipients, over 60% were transplanted within 12 months of listing with a domino case, and an additional 20% were transplanted within 12 to 24 months of listing. So we then wanted to look at the domino explant allograft and how this compares to the current US donor pool. So in 25 years here in the US, 210 patients underwent transplantation with underlying amyloidosis, and over 50% of these allografts have been discarded. So only 49% were subsequently dominoed. When we looked at maple syrup urine disease, 227 patients underwent transplantation during the study period, and only 22% of these allografts were subsequently dominoed. For familial hypercholesterolemia, again, only 13% of these allografts have been dominoed, and the vast majority have been discarded. And for hyperoxaluria, less than 1% has been dominoed, and it's worth mentioning at this point that the literature is consistent in that hyperoxaluria allografts are perhaps not suitable for domino transplants because there is an association with end-stage renal disease. But nevertheless, if you look at these, just these 4 diagnoses, 600 livers have been discarded in 25 years. So we then wanted to look at the current US transplant waitlist, to look at the number of registrants with hereditary familial hypercholesterolemia, hyperoxaluria, maple syrup urine disease, and amyloidosis. And we found that at the moment, there are 94 patients with these 4 diagnoses waiting for transplantation. And I guess theoretically, when the time comes and when these patients are being considered for transplant, the question can be asked, will these grafts be wasted or will they be considered for domino transplantation? Lastly, we looked at patient survival. And encouragingly, when we looked at graft survival and overall survival, this was well over 70% at 5 years and over 50% at 10 years, and this seems to align with standard deceased donor transplantation. But we then wanted to look at adult and pediatric domino recipients and how their outcomes played out. So for adult recipients, again, there were no statistically significant differences in outcomes for both graft and overall survival when the allograft came from a pediatric or an adult donor. And again, 5-year survival was over 70% and over 50% at 10 years. Although the number of pediatric recipients in this series was low, encouragingly, again, there were no differences when it came to outcomes based on whether the donor was a pediatric or an adult, and again, graft and overall survival remained excellent. So to conclude, domino liver transplantation has really yet to become mainstream here in the US, and to date, they've only accounted for 0.1% of all liver transplants. There is a potential to expand the current donor pool, and this approach could be useful for this. And if we look at the current wait list, you could potentially identify patients with suitable allografts that can be dominoed. We have seen acceptable long and short-term graft survival here now in the US and certainly overseas, and 5-year and 10-year survival remains excellent and comparable to other standard liver transplantation techniques. Certainly clear indications and guidelines are warranted to help identify suitable domino donors and their recipients. And although this may form a small number of the overall donor pool, it could still certainly produce a non-negligible increase in an effort to expand the donor pool. Thank you for your attention.
Thank you. This paper will be discussed by Hugo Pinto Marques from Portugal.
Thank you very much for this fine paper. I would like to thank for the privilege of discussing the paper. And this nationwide analysis raises the question of the potential expansion of donor pool given by domino liver transplantation. And it's very interesting. I have some remarks. First of all, this study reports a total of 187 domino liver transplants on 42 centers. However, there is another recent study using the same database in a shorter period that reports more than 200. So there's a chance that you might have missed some dominoes. It doesn't take any of the value of the study. It's very interesting. And I would like to ask some questions. There are essentially two types of domino liver transplantation techniques. There is the classic and the IVC preserving technique. There is no mention to the type of technique, and I wanted to ask you if you looked at this and you realized if there was any kind of difference in terms of survival of the patients transplanted with those two different techniques. The second is about iatrogenic amyloidosis, since amyloidosis is the most frequent indication in the States, as it is in Europe also. So, did you look at the amount of patients with iatrogenic amyloidosis after the domino liver transplantation, and how many of those were retransplanted or not? Also, there is a trend towards a reduction in the number of domino liver transplantations. Can you comment and explain it in relation to the current systemic therapy? And finally, do you recommend the general guideline about the selection of patients that should be proposed to domino liver transplantation? I think overall this is a very interesting study. To my knowledge, it includes the largest series of patients submitted to domino for maple syrup urine disease, for example. But first of all, I think the conclusions are very important and highlight the need for a better use of those grafts, and I congratulate the authors for this. Thank you.
Thank you very much for those comments and for that feedback. I guess just to go back to the methods, we extracted data based from UNOS. So we're limited by what UNOS has to offer, and unfortunately there's no information on techniques and what's used. In our center though, however, I can comment that when it comes to the primary recipient, we use a bicable approach, and then when it comes to the secondary recipient, we do a standard piggyback technique. So yes, it would be interesting to do that. Again, that's limited by UNOS, but doing a multi-center analysis could certainly answer some of those questions. When it comes to the comment about amyloidosis, I guess most of the literature is really focused on amyloidosis and domino because it is the most common. It's certainly much more endemic to Europe as opposed to here. We didn't look at data for de novo amyloidosis because, again, we were limited by the UNOS database and what's being captured. It's certainly an important comment to make, and I guess when you're looking at these patients on the wait list, if you've a patient with amyloidosis on your wait list and you're considering this for a domino, that's certainly an important topic to bring up with a suitable recipient about consequential metabolic disease. Will UNOS capture that data? I don't know, but if they do, it would be really interesting. I guess then when it comes to the numbers and why the numbers, it was encouraging, I think, at the start to see the numbers increase, and again, the first one was in 1996. Why the numbers dwindled down is hard to explain, again, because we are looking at a number of centers. I think the conventional explanation for this is just the prevalence. There aren't that many patients around the place with amyloidosis or maple syrup urine disease, but I think that's that's an easy comment to make. I think an alternative explanation could be many programs just don't think about it. If you don't have a pediatric program or if you're not used to looking at metabolic conditions, domino is really the last thing on your mind. I think maybe the lack of consensus guidelines when it comes to identifying suitable donors and recipients, logistical challenges. A lot of centers will not be able to accommodate 2 transplants happening at the same time. And again, I think one of the comments that was already raised is really consequential metabolic disease and whether that's been fully defined in the literature. So those are potential explanations as to why we haven't seen that increase. When it comes to general guidelines, we're certainly, I think, raising awareness and discussing it at these forums is certainly useful, and that can help generate discussions and generate guidelines. I think historically, even just looking at the literature, most of the domino cases seem to be limited, not limited, but they're offered to patients who are a little bit older, again, just to avoid the consequential metabolic disease, and whether dominoes should just be limited to that group. I guess the honest answer is I don't know. It could certainly be useful, but even if we just look at the current US transplant candidate waitlist, the number of registrants over the age of 65 has doubled in the last decade. So even if you can just target that group and just focus on dominoes for that group, I think it could be a non-negligible change.
Thank you.
Thanks.
One question. According to our experience in Argentina with domino, there is a controversial issue about how to distribute these livers. If the domino must be done, the donor and the recipient from the same team, of the liver must be gone to the pool, and the pool is distribution in the different teams. What is your way to distribute domino in the US, and how's your comments about that?
That's a really good point. I think at the moment it's institutional. So if you have, it happens within your institution. But certainly I think going forward, if this is going to become part of the mainstream, we could look at it sort of in the same structure as we looked at the paired exchange program for kidneys. So to allow for a greater transfer and export of these livers. And certainly with the advent of machine preservation, whether it's normothermic or hypothermic, that could certainly help facilitate that. So although at the moment it is institutional, I think there's room for broader sharing.
Thank you.
Thank you.
Thank you very much. That concludes our session.